Good afternoon, everyone, and good morning to our colleagues joining from the United States. Welcome to the 5th edition of the Public Health Research Club. Thank you all for being here today. I'll let people join. Okay, one more minute. Okay. Okay, so it's 3 p.m. for France and 9 a.m. for US. So good afternoon, everyone, and good morning to our colleagues joining from the United States. Welcome to the 5th edition of the Public Health Research Club. Thank you all for being here today. This series is organized by the Public Health Institute and IReSP with the aim of highlighting innovative research, fostering scientific exchange and building stronger connection across discipline and institution in public health. Today, our focus is on a topic at the heart of health research, from bench to bedside to society, integrating public health, medicine, and research for population health. To explore this very interesting subject, we are truly honored to welcome Dr. Victor Zhou, President of the National Academy of Medicine in the United States. I will introduce briefly Dr. Zhou, so it will take far more than a few minutes to do justice to his remarkable career. So Dr. Zhou, you are an internationally recognized scientist and leader whose work has transformed health and medicine, both in the US and globally. Your pioneering research in cardiovascular medicine and genetics led to the development of new drugs for hypertension and heart failure, as well as gene therapy for vascular disease. It is notably your work on the renin-angiotensin system that shaped your strong interest in translational research, if I'm not wrong. Since 2014, you have served as president of the National Academy of Medicine, and you have strongly promoted the concept of discovery to care continuum, which you expanded in 2021 to include society. I could go on. There is a lot of contribution you have made to health, but I know everyone is eager to hear from you directly. So just a quick reminder to all, the presentation will last about 40 minutes and will be followed by a 20-minute Q&A session. So please feel free to share your question in the chat. Thank you again for joining us today. And without further delay, I am pleased to hand the floor over to Dr. Zhou.
Thank you very, very much, and bonjour. I'm afraid I'm not going to be able to present in French, so I'll have to do it in English, so forgive me. I am indeed a physician and scientist. Of course, I lead the academy, which is a full-time job in the United States. My background is really in physiology, molecular biology, and of course, medicine. And my research, as you heard, is on renin-angiotensin. So you can imagine my very good friends, Pierre Corval, Joe Menard, are really good friends that I've known for many years, and we have been colleagues in doing the research in this area. The title of this talk is Bench to Bedside to Society, because at least in the United States, and I think UK, we characterize the medicine and research from the bench, laboratory, to bedside, to a clinic, and of course, hospital. And I want to make sure that we include the consideration in society because so much of health is affected by social issues, etc. So hence the idea of bench to bedside society. I'm not a public health expert, but I certainly recognize increasingly, as many others have done, that the importance of public health integrating with their care delivery, and of course, ultimately looking at the improvement for population health. And that's the talk I'm going to give today. Presumably, many of you already know some of these concepts, but I would say that this is coming from a medical point of view, but recognizing, of course, the importance of public health. Next slide, please. So first, the very good news. If you look at the past century, we have almost doubled our life expectancy. And this is really, really impressive. And now the average life expectancy in 2023 is 73 years old globally. And that's because we have just major advances in public health, in science, and in technology, with increased hygiene, improved nutrition, vaccination, reduction childhood obesity, tobacco control. Of course, the importance is the improvement in diagnosis and in treatment. So if you look at disease burden, I'm a cardiologist. There's in the United States, there's a 50% reduction in cardiovascular mortality in the last 50 years. Sorry, very impressive. Next slide. In France, you have a great health system. In 2025, you celebrate 80 years of Sécurité sociale, the universal social security program to provide healthcare to all. And of course, it offers citizens an excellent healthcare system with really strong protection of health expenditures. 80% of health expenditures are covered by the government. So it's really one of the highest life expectancies at birth in the world. And the disability-free expectancy at age 65 is steadily rising in France. So on average, a woman can expect to live in good health until the age of 77, and a man to 75.5. Very impressive. Next slide. Because you know that every system is facing major challenges. And one, of course, is fiscal challenges. As we provide the care and the financial coverage, and as healthcare becomes more complex, demand goes higher, the cost of the system is getting higher, and France ranks among the highest OECD countries in health spending, almost 12% of GDP. Of course, it's not as high as the United States, but it still is very high. And the insurance cover, 80%, as I said, and of course, the deficit is now reaching 13.8 billion euros in 2024. This is in addition to, of course, more and more demand for health and healthcare, with high proportion of deaths related to behavioral and environmental factors, rising chronic disease, and of course, aging demographic. So France is not alone in facing this issue, but certainly it too, like everybody else, is facing many of these challenges. Next slide. So let's take a look at disease burden. Here you can see, like United States, like most OECD countries, the top disease burdens are by cancer, cardiovascular disease. What's of course interesting, in my country, cardiovascular disease continue to rank number 1, cancer number 2, but in your case, cancer is very high. As I said, if you look at the rest of it, chronic disease is responsible for the majority of the challenges you see in France. And of course, aging population, environmental and behavioral risk factors I mentioned, but also what I call health and social inequities. Next slide. Our country is particularly bad, as you know, of those who have and have not. But even in France, the overall life expectancy is affected by education and socioeconomic status. Life expectancy for men with a tertiary education is 8 years longer than those without secondary education. The gap is huge. And of course, socioeconomic status, particularly those lower status, report much less in good health as compared to those who have higher incomes. You also face a major issue, as we all do, of having doctors and healthcare providers in rural and peri-urban areas. So you can see the big challenge that you're facing, like everybody else, despite the fact that you have an excellent system. Next slide. So this is in the setting, of course, of global changes as well. We know, as I said, the global disease burden of NCD and population is rising indeed. But also, as you have just lived through the pandemic COVID-19 and more emerging infections. I was just with my good friend, the Jean Kaseya, the director of Africa CDC, at the World Bank meeting, and he says, if you look at outbreaks, in Africa, it's almost one a day, over 200 some outbreaks in a year. So, and the outbreaks, emerging infections are getting more and more severe, more frequent, and therefore the chance of pandemics is also rising significantly. As people say, it's not an issue of when, it's not an issue of if, it's an issue of when. We're also facing climate change, extreme weather events that is, of course, impacting enormously on health, directly in people's environment, their livelihood, but it's also causing displacement, lots of refugees, famine, drought, and you name it. And I already talked about care environment is changing because how demanding, how complicated, but also the rise of AI. We face in our country, as you do too, and globally, doctors, nurses feeling burnout, and many are leaving the profession. We see the social inequity as you see, but in our case, our country, much worse. And of course, we see the mistrust in science and misinformation. I think all this simply says we are reaching an era of rapid changes and that we need to look at how to respond to these changes and maybe change the way we do things altogether. Next slide. So in this context, I think it's important to remember, as a doctor, as I was trained, I think about a disease. But in fact, we have to think about health. In fact, we have to understand that health is affected by so many factors outside, of course, healthcare, for example, social environmental factors, and of course, we are connected more than ever, particularly easy travel, and of course, the spread of infectious disease and others. You know, the data is very clear, certainly from our country, that if you look at total health outcomes, healthcare, the treatment and diagnosis of patients' disease accounts for only 10 to 15% of outcomes. The others are genetic factors, social factors, and behavioral factors. And we need to address this in order to improve health altogether. Next slide. So I wrote this paper in Lancet that as we enter this new decade, there's a compelling need to revisit the model of medicine and the function of health systems and to redefine their future. Hence the idea of a bench to bedside, to population to society. Because traditionally, doctors' healthcare system look at bench to bedside. And of course, we have to think about the population, and we have to understand the social factors that influence health and hence society. Next slide. So let's look at our tradition. Traditionally, we deliver healthcare by having, of course, very important, all of you, public health and community health. Also primary healthcare, second to tertiary hospitals and centers. The problem, at least we face in many places in our country, is all these three entities function somewhat independently. They're fragmented, they're not connected together. So that when one sees a primary care physician, there's almost no or very little connection to the idea of nutrition, public health, and certainly when you have advanced diseases, you end up with a specialist. There's very little connection with primary care, public health, and you name it. So the priorities and management are not aligned because each one looks at what's best for its own situation, including financing. And of course, it's highly disease focused. Most of your budget is into disease, much less prevention and health promotion. Next slide. In research, we have the same problem. We look at biomedical research, basic discovery, preclinical, translation, clinical, implementation science, but all these are in fact not connected when you look at funding agencies. Also, as I said, what's more important health outcomes, in fact, is social science and public health and data science, but importantly, policy, because social policy affects so much the way that we look at health and healthcare. So law, economics, etc. So this spectrum research also takes place in different entities and organizations. Funding is siloed, and there's no strategic plan to integrate all this around health, and therefore, and it's not usually integrated with clinical care and education. Next slide. So what is the problem? I think what we're finding is increasing fragmentation, disconnection between providers, clinics, organization systems. Data are poorly linked because each of the hospitals, at least in our country, not in yours, and public health have different data systems, and there's not good interoperability. There's lack of connection at all levels, so shared decision making, holistic approach, and of course, insufficient link between health, healthcare, public health research, and medical education. I'm not saying it doesn't exist, but I'm saying that it's not very good because we all work in silos. Next slide. So what is the solution? In my first paper in Lancet 10 years ago, I said we need systems integration. What the nation needs and what overall health needs is an integration first of care, that from tertiary to primary to population health, all integrated under one system, that research should also be integrated, and that we should integrate care, research, and medical education all together, so that for our public, for our patients, the right care, right time, right place, and that we need continued communication, coordination, collaboration across systems, providers, and settings. Next slide. So the key point I want to make today, number one, is we need to bring together medicine, community health, public health, and important social services. Because as I said, if social factors are a primary driver of health, we must be able to provide good social services. Now, France is very good at this. If you look at almost most countries, you're among the leaders in spending almost equal in social care and healthcare. In our country, 80% is spent in healthcare and only 20% in social care. So in bringing together primary care and public health, we can improve outcomes for both sectors. For example, the use of data, the use of geospatial mapping, where you can say in a community, where are the clusters of patients with diabetes? Then you can also say where are the clusters of good food, nutrition, access, grocery store. And you can also look at where the clinics, primary care clinics, which they can access care. So that involves bringing data together from public health and primary care. And of course, social factors, so important. Jobs, poverty, housing, education, and we need to address the social vulnerability so that as we integrate social care into care delivery, of course, it improves the care of the patients altogether. Next slide. So this leads me to the concept of population health. The National Academy of Medicine US used to be called the Institute of Medicine in 1998, was the first to coin the term population health. And what we're saying is we as a society do collectively to assure the condition in which people can be healthy, the population. That means health has been looked at for entire communities and reducing health inequities. That means we need to provide preventive tools and health promotion. That means we need to intervene very early for those with risk factors. And that means we need to consider social, environmental, and behavioral determinants of health. And how do you actually address them? Next slide. So it's really interesting that C.K. Francis, as early as 2001, wrote this paper in the Journal of National Medical Association. He said, you know, we need to think differently now. There's a need to balance medicine devotion to well-being of the patient and the primacy of patient-doctor relationship against the need to meet the healthcare needs of the entire society. The challenge facing medical profession in the new millennium is to establish equilibrium between responsibility to ensure quality care for the individual patient while affecting societal changes to achieve health for all. I think that's really a prescient statement and an important part of medical ethos and social responsibility. Next slide. So I wrote this paper, in which I say, if you look at the whole spectrum of health and medicine, from discovery research to translation to adoption, implementation, to affecting population, and we need to add also considering society. This whole spectrum needs to be integrated as a systems approach to health and medicine, hence bench to bedside to population society. Why society? Because first, we have to look at all the work that we do and understand what are the societal implications of what we do. Let's take AI. Let's take new treatments. What is the impact on society? Well, we know that number one, we are concerned about affordability of CAR T therapy, gene therapy, and many others, which is costing a lot of money. How do you make sure that's affordable, accessible? We know that AI, which has tremendous implication, can have, shall we say, harmful effects. How do you make sure that we address this society? We know that health impacts economics, security, and ethics. So we need trust from the community. And trust is such an important society that affects all that we do in science and clinical care. Of course, we need to understand the environment and climate. So in this paper, I say the future requires a systems approach and the fact there are four major drivers that we need to now embrace in order to achieve systems approach. Next slide. They are, number one, convergent science, to bring all the sciences together in order to look at how to improve health and address population health. They're about data and digital technology and AI. They're about engaging the community, not in our ivory tower in our office or in our hospitals, but addressing social equity. They're about the workforce for the future. For the remainder of my talk, I'll talk about these four areas. Next slide. So first, convergent science. In 2014, the National Academy of Sciences, Engineering, and Medicine, my organization, wrote this very important paper to say we need convergence. We need to bring science together, and we need to go beyond multidisciplinary collaboration. So what's convergence? Well, we know we need to collaborate across disciplines, and we collaborate. But convergence is bringing together the necessary sciences to focus, to solve a problem. As I say, a unified whole to solve vexing problems. MIT subsequently also wrote a report to say that's the future of medicine. Bring together not only medical science, but computation, mathematics, engineering, social behavioral sciences, data science, and more. And of course, if you look at ultimately the application of all this in moving from the bench to bedside to population health requires convergence to solve the problem not only in health, but also together in economics, in social science, behavioral science. And I wrote a paper in Lancet to say population health is a practice of convergent science altogether. And of course, the recommendation is that we need to build strength. While it's really true that these specialties exist in the university and many others, within health and medicine itself, we need to not only go beyond traditional medicine, but we need to bring these sciences together, and we need to bring our own core capabilities, such as data science, in order for us to be able to function. And we must, in medicine, align with public health. Next slide. In this regard, data is so important. And you all know this. The last decade, we've seen massive growth in the availability of data, from patient data to systems data to public health data to social environmental data to research data. All these need to be brought together because big data allows us to precisely examine the specific public health risk and customize engagement to subpopulation. but also understand patient environment, social factors in which they function so we can provide much better care. And all this, when integrated, we can generate real-world data and evidence in order to be able to create hypotheses, but also actions going forward. Because you all know this, we need data sharing and data interoperability. Next slide. So that leads to, of course, the question of AI, which is on everybody's mind. Everybody in society and healthcare, because AI can do so much. It can create operation efficiency so that our clinics, our hospitals, our public care are a lot more efficient to support the patients and to help them determine what's the best optimal pathway. And of course, it would need data, and of course, unbiased data, large data sets. So you can see AI can improve diagnosis more accurately and faster. It can target populations. It can target potential treatments. It can help monitoring patients and adherence to their medication. It can reduce variability in care, align workflow with automation, and of course, help patients to generate their own work and reports. But we all know there's tremendous risk in AI as well. We all know that the bias algorithm, so much data is collected. For example, in our country, in white male, where, of course, substantial amount of our population is non-white, and of course, more than 50% is women. So when AI make algorithms and advise, it has to have data sets that's unbiased. We're concerned about privacy and cybersecurity. We're concerned about generative AI's hallucination and error. Right now, the big concern, of course, is governance and regulation. You're better in Europe and OECD with more regulation. Our country, which is so driven by economics, wants to do as much as we can, move faster. Of course, the regulation is not so strong. And of course, there's tremendous potential of misuse. Next slide. So if we do it right, I think the future of health and medicine is very bright. That we have tools to get more effective prediction prevention. We understand much better the patterns of diseases and public health. We certainly can change how care is delivered virtually, where care is delivered, and who is care delivered by. Community health workers with, of course, digital systems and AI. There will be, therefore, reduced fragmentation, if you will, a better continuum, as I said earlier, by digital connected, monitored continuously without interruption. And of course, the insights from AI, big data, of course, digital assistants can really help personal healthcare decisions as well. Next slide. But we are quite concerned about issues. So at NAM, National Academy of Medicine, we've done a lot of work addressing issues of AI and misinformation. You can see that we've looked at the issue of generative AI in health and medicine, how to use it, what are the risks. We have created a code of conduct of the use of AI in health and medicine. We're now looking at how to help clinicians and educators look at AI in health and medicine. And misinformation, we're doing a lot of work on misinformation, including looking at social media and others, and of course now helping digital and technology companies such as Google to make sure that the answers to many of the social media frequently asked questions are accurate by us having a way to help them machine learning adjudication of the accurate answers. In this case, in nutrition, the 100 frequent asked questions. After I finish our work, I have a paper coming in the New England Journal of Medicine, will be at least validated by the experts, and therefore people can rely on those answers. So that's what we're working on. Next slide. So AI has tremendous application for population health. It can look at risk and epidemic forecasting, look at healthcare data or health data overall, real-time monitoring, surveillance, chronic disease management, and many others. Next slide. In France, you have addressed this issue head on, As early as 2004, you have a Public Health Act that introduced provision for large-scale data integration. Very impressive. In 2017, you launched a unified health data system, creation of Système National des Données de Santé, which covers the entire population of France. And you have used secondary use of health data to look at governance, citizen rights, ethical data reuse, expand database, create categories of data sets, simplify Excel data use, and many, many others. And of course, you also have a strategy on AI, regulating, ensure compliance, evaluate the systems, train, support health professionals, and build an economic model for AI tools. So congratulations, well done, but I'm sure it's still full of challenges. It's not so simple, as we all know, right? But you are at least addressing it in a system level. Next slide. So I want to emphasize the third point. I've talked about convergence, about data in AI. Let me talk about equity. As I said, there is in fact disparities in each country, and our disparities in the United States even is between zip codes. That is, within the same city, there could be as many as 30 years of difference in life expectancy between the rich zip codes and the poor neighborhoods. And many of the early deaths are related to what they call the diseases of despair. Despair because of poor socioeconomic conditions, of suicide, gun violence, of overdose. And so we must address the issue of equity. We must look at social determinants. We must work in healthcare and public health with community organizations, community-based organization to address together social issues. How do we work with other social agencies to ensure better housing, job creation, food security, very important, education and career? We have to recognize the relationship between health and society. Oops, can you go back? In the paper I wrote in Lancet, I said there can be no health equity unless there's social equity, which simply means that we need to look at our social policies and work closely with decision makers, advance policies to promote social equity, cohesion, trust. We must tackle misinformation. Next slide. And finally, education. As you hear where I'm going, I think we need to really develop a new generation of health and health workers that's skilled in social determinants, in public health and healthcare, in new technology, and look at data, in policies, and in management leadership and interprofessional skills. Because our current model is disease-centered, not health-centered. It emphasized acute care. It fragmented and poor teamwork. It looked at episodic encounters with patients. There's insufficient understanding of community health. There's not a lot of training information system. And of course, the mismatch of competency of patients and population needs. Next slide. So the future workforce must create a new type of clinician that's community-oriented and socially connected with skills in communication. It must work with partners to create new curricula and competencies in team science, in social inequities, in quantitative science, such as data. Students should be exposed very early in community and social issues, even before they get into the clinics, so they understand the background of the population they serve. There must be training for clinicians already in practice to continue training to make them up to date on these issues. And of course, the use of data and digital technology. And of course, finally, as in our country in France, you have to diversify your workforce because cultural issues and many issues which are so important in your population of immigrants and others you have to have workforce that can reflect their understanding and the population they serve. And of course, in our country, we need to rebuild public health workforce altogether. Next slide. So 10 years ago, this is a famous paper in Lancet they called a Commission on Workforce for the Future, led by Julio Frank, who is now the chancellor at UCLA, who one time was the Minister of Health in Mexico and the Dean of Harvard School of Public Health, along with Harvey Feinberg, my predecessor, and others, to say what we need to do in education is to be sure we're educating effective workforce must be aligned with the needs of health system. I'm adding to the right my own writing. I say now more than ever, we also take care to be aligned with community, population, and societal needs. Next slide. So I wrote another paper in Lancet to say, traditional medicine, has it had its day? Do we need to redefine what medicine should be? As you can see, I say medicine must extend from traditional to promote prevention, align public health societal needs. It has to redefine its historic model by extending a bench to bedside approach to capture, integrate population and societal health. My final slide, please. Ladies and gentlemen, I think we are undergoing tremendous change, health and medicine. We must make the changes, be proactive, staying ahead. I think what we're seeing now is a shift from reductionist research to systems approach. We're going to multidisciplinary convergent science. We go from individual to team science. We go from molecules to population health. We are now evolving to big data information science. We have to go, as I said, from discovery to translation, healthcare delivery, but also science, regular science, but population and society. And of course, let's not forget, we live in a global world. We have to look at local, regional, national, and global activities. Thank you very much for attention. You can have the slides off, please,
Yes.
Laureline.
Yes. Thank you very much, Dr. Zhou, for this presentation. It was really, really interesting. Don't hesitate to ask your question in the chat for the Q&A. I have a first question. Okay. So you talk about trust in science in population, and I would like to know if you have some ideas on how we can improve as scientists, as researchers, as medical population. How can we improve the trust in science?
This is a very, very, very big issue. The trust in science, trust in health, trust in healthcare, trust in information. Let's begin with the science. I think we as scientists all feel that we are pursuing the truth. We are pursuing what we can find in the scientific rigorous fashion, and that we have scientific data and evidence. And that's all true. But first, we need to recognize the science is an evolving area, and it's always what they call self-calibrating. What we understand today may change tomorrow because technology is getting better, information is getting better. So we have to be very humble to understand that what we say could change. I think during COVID-19, it was the dogmatic approach of science that created a lot of concern and mistrust, right? If somebody says today, you must all wear masks and you must close all the schools, and tomorrow some say, well, maybe we don't need to close all the schools because it's affecting, education, and there's not much evidence that it's causing spread. People get very upset in mandatory issues. Now, I, as a public health person, say, of course we need public health policy because it's for the greater good. But I think we need to explain this in such a way that they understand that we are using the best evidence possible to do the best we can possible. Be able to say what we don't know, we know. That's number one. Number two, as a scientist, I commit the sin frequently of showing data. Look at this graph, look at the multi-points, and look at it's compelling. If you understand this, of course, you should accept it. We understand that's not going to work these days. We need much better communication. Communication is a science, it's an art. And so, therefore, more and more of us are now saying we need to combine data with narrative. Tell the story. Tell the story of this young girl who's suffering from this situation and how science can help them. Tell the story that every day you don't realize that every day, everything you do, metro, iPhone, you name it, it's all driven by science. Where are we today without science? But tell the story and being able to speak to the public, but also speak to the decision makers. You know, politicians have so little patience. They all want to think about what is the best way to convince, to get vote and hold it. So you need to give them the information, support them. And finally, the most important one is being willing to speak to the public and to the community. So too often we don't speak to the community. Much of what we're doing these days is to go to neighborhoods, to go to communities, to go to your different, areas to speak to the people. And number one is to say, what are your worries? What are your concerns before you preach to them? So you need to listen to concerns so that they can trust you. And then you resonate and you're there, of course, to see what you can do to assist them. So that's number one. So science had to change totally in terms of the way it does things. Secondly, trust is a very complex issue. It's individual, it's institutional, it's population, it's community. In America, for example, we had the famous study called Tuskegee, in which the African Americans were undergoing experimentation without concern, in this case for syphilis. Of course, the people say, we don't trust the government, we don't trust the researchers, what they do. So we have to imagine historical trust, individual trust. I trust my doctor, but I don't trust the hospital because they're so difficult to work with. There's so much complexity. They don't listen to me and they cost me too much money, right? So that's individual trust. I talked about community trust. You talk about scientists, AI. How do you trust AI? So what we're now proposing, and I have a paper now written, is that we need a systems approach to trust. Just like everything else, if you look at patient quality and safety, it's not the individual doctors, it's the whole system that improves the health, quality, and safety. We need to create a system of trust that every single piece is moving collective same direction. Finally, we have to use social media. I already told you that we are working with Google and others to be sure that data that comes out is accurate and assures where they can say we have, in fact, the National Academy of Medicine, College de France, others that the experts say these are accurate. That's really, really important. We also need to think about how to use social media. We're now looking at, the content creators, some people call it influencers, to see how they can use a method to talk to the public with science-based approach altogether. So thank you.
Thank you very much for this very interesting answer. I have another question. Do you see AI playing a role in linking chemical exposure data to disease outcomes and their underlying mechanics?
Oh, yes, very much so. I think you mean, is AI creating a problem in the environment? Is that question?
I think the person
Yeah.
who asked the question, maybe you can tell me in the chat. I think it's this, yeah.
Yeah. So yes, AI is, as you know, is highly energy intensive and also water intensive. And so it is becoming a problem that can create environmental problems. The data centers that we have I'm sure you have them too, that they in different cities or different regions is really creating a tremendous amount of problem. So there are discussion about what in fact are the, shall we say, safeguards, if you will, to regulation of that, right? But I think there are many people addressing this. But it's also, AI can also use in the other way, which makes it less carbon emission and less energy intensive by allowing to support the electric grid, to look at what's the best way to use energy, to look at supply chain. So it's a dual-edged sword, in my opinion. We need to lower the energy requirement of AI, but we also need to use AI to help us improve the environment.
Yes, I see the other question are likely the same. I will ask the question anyway. Yet you have emphasized the role of social context as major determinant of health, yet the most disadvantaged population are also disproportionately exposed to environmental risk. What are your thoughts on a model of public health that integrates its own environmental impacts into the way it operates? For instance, shouldn't we consider the environmental footprints of data center at the same time as we plan their integration into care pathway? Okay, that was a long question.
Yes, I hope I got most of the question, but let me say, first of all, the our colleague that asked the question is right in the sense that I've said social and now environmental determinant health. So there's clearly environment with, environmental with air pollution or energy or water. These are very important issues. So we have to consider this totally in the consideration of health altogether. I do think that in this regard, of course, we now have to integrate science into the issue of health environment. As we look at climate health change and health, we've looked at environment and health. I think the issue of AI, I think we already talked about. I do think that I feel that AI is going to be extremely useful. And like it or not, it's a way of life already happening, and it's going to be a lot more. So I think our job will be to make sure we use it effectively and usefully to improve health, also to look at AI, look at environment. As I said, AI can be very useful looking at energy sources, supply chain, management of energy, electric grid, and others. At the same time, we need to minimize its carbon emissions, use of energy. Thank you.
Thank you. I have other question on other part of your presentation. For example, how can policymakers be better integrated into the research continuum without compromising scientific independence?
This is so important. For a long time, I and many others said, we need to be just doing our research, and we need to focus our research and not be distracted by other issues, because that gives you the best immersion. For a long time, we talk about, if we begin to get into politics, it's going to affect our research. That's all true. We must remain independent from politics, but we can be involved with policy. That's different, right? The right policy. So I think it's really important to have more and more policymakers understand the importance of science. I was told an anecdote, a story told by somebody who, at a meeting with scientists talking about this issue, one scientist says, you know what? I actually reached out to my Congress person, and he met with me, and he says, you know what? I listen to people all the time coming to my office about things. You're the first scientist to come and talk to me about science. That means we're not getting our message out there. So in my job, at National Academy, I've gone from being a doctor scientist to understand how important policy is. So any option I have, I want to educate, not advocate, educate the policymakers. I want to inform them so that they can make the right decision. I want to be able to shape policy that's good for science and good for health. So I think we need to be a lot more proactive than just simply sitting in a laboratory. Now, it's more difficult for younger people, but for us senior people, we really should do more than just, staying in the lab. We have to advance science through policy, and that's better for society.
Thank you. I have a lot of people saying thank you so much for this inspiring presentation. Thank you for taking the time to share your important work with us. And I have a comment about what you talk on policies. I find it interesting. It's all your point and recommendation resonate a lot with the Ottawa Charter's framework that I wish I could be used more systematically to inform the design of public policies. It's just a comment from one people. I have another question. In your experience, what are the most persistent structural barriers that prevent breakthrough from moving effectively from bench to population level impact?
Oh, this is a big question for me because I would say a lot of what I'm thinking today is to say, how do we actually get great science to the public? So the model that we all use in many countries is you support excellent basic research in universities. When you have a discovery, you can therefore license or transfer to companies so because they have the money and capability to make a drug, a device, a product, to be able to put in the market, to be now make available. This is a model called market-driven innovation. That is, great research in universities, take the research and put it into public through companies. The big problem there, this is, by the way, very successful. You have Sanofi, you have, many great companies, you have many important companies and in France, and of course, where the pharma and others have great products, great breakthrough. And of course, you have great research, Emmanuel Charpentier, CRISPR. Now, the problem is now taking CRISPR to make it affordable to everybody, to make gene therapy affordable. That's where the big problem is, in my opinion. That's number one, right? The second problem is if there's no market, there's no product. So there are lots of problems that people that we all live with, like mental health, like women's health, that in fact there's no products because companies say it's too risky and I don't have enough return investment. So that left also behind this big gap. So today's model of economic market-driven innovation is successful in creating big economy like Sanofi and others, in creating great products, but also leave a lot of people behind, especially in our country. So I think we have to change. Now, if you have a chance, please read my paper in Nature 2 weeks ago, April 6th or 7th. I think it's online, maybe it's in paper now, that discusses this issue, why our system is not addressing the needs of the public if you only use market approach. And I'm now working on the project of a new public-private partnership, in which we want the government to play a larger role to address the gaps which are now left open by the market-driven economy.
Yes, thank you. I will try to find your paper and share it with our audience because it seems to be very, very interesting. I don't have any other question for now. I will maybe close this session So you will have 5 minutes
So,
to bring.
so
Yes.
Laureline, this weekend I'm coming to Paris.
Oh, wonderful.
Yeah,
Really happy
yes, I'm very
to hear
active
that.
with your G7, and I was in Lyon, Macron's
Okay.
meeting on One Health, and this weekend is going to be the finance. It's the agency for development,
Okay. Oh,
in
yeah.
which we're going to talk about financing health. And I'm going
Okay.
to speak about my work on the G20 panel on financing health, and it's hosted by the AFD, Agency for Development, and also by
Yes.
OECD. So I may
Oh,
run into you on the street.
yes, maybe, maybe. We are really happy to have you in France. So, and really, your work is really inspiring for us. I think everyone like it very much. We have a lot of thank you in the chat. There will be a replay, so if you want to share it later, it's our pleasure. Enjoy your stay in France when you will be there. And really thank you for being with us today.
Well,
I will,
I hope to see many of you one way or the other. And of
yes,
course, I had the chance of meeting Robert, and that's
yeah,
how I got to come. And of
yes,
course, I've been quite now active in interacting with your Academy of Medicine and the
yes,
Academy of Science. Thank you.
yeah, we are really happy about that.
Yeah,
Thank you.
thank
Have a
you.
nice day, everyone. And thank you very much, Dr. Zo, again.
Yeah, thank you.
Bye. Bye.